Good evening and welcome to ULIZA Daktari. This is your show where we tackle all matters health and answer all your questions related to your health. Now, this evening, I am your host, Dr. Lauren Mengesa, yani Daktari wa kina mama. I am an obstetrician and gynecologist. I'm based at Akira Care and at the Nairobi Hospital. Now, last week, we started a very emotive and interesting discussion on a phenomenon known as recurrent pregnancy loss. Yani wale wanawake ambao wamepoteza mimba zaidi ya 2 na bado wakipata mimba nyingine tena wanapoteza hiyo mimba. We looked at what is recurrent pregnancy loss and what are some of the causes. And some of the questions coming in are, what can we do about this? Now, one of the ways that we solve this problem called recurrent pregnancy loss is something called a McDonald stitch, or another version of it called a Schrodker stitch. Now, what you're looking at is a photo of one of the first times I put this stitch, and I did this alongside my professor who has joined me on this show, and this is something called a Schrodker stitch. Now, hizi stitch ni zile ambazo zinawekwa kwa wale wanawake ambao ile shingo ya njia kizazi ama ile inaitwa cervix has a problem, and this allows us to allow pregnancies to progress beyond the point where they would have lost this pregnancy. Now, on this show, joining me is Professor Mondio Gutu. This is a renowned gynecologist and obstetrician who's been practicing over 40 years, and he's a maternal fetal medicine specialist. Karibu sana, Professor.
Thank you, and pleasure to having me with you today again.
Maybe Kenyans want to know, when we say MFM, maternal fetal medicine, ni nini haswa tunamaanisha tukiongelea MFM?
Maternal fetal medicine means that is that branch of obstetrics and gynae which basically looks at the well-being of the mother and the unborn baby till the two are separated. It's a special entity on its own as part of the major discipline of obstetrics and gynecology.
So Professor tells me that over 80% of the patients he sees in his clinic are actually patients who are struggling with recurrent pregnancy loss. So you are not alone, and if this is your struggle, please join us on this show because we have a lot for you to learn. Our SMS lines are open on 22422, and our socials are alive on ULIZA Daktari and at Daktari_Mengesa. Now, our proud sponsors of this show are CIC Insurance Group. Now, CIC has a package for the family that ensures that you're covered when you go in for your checkups, for your antenatal care, and for everything medical aid for the family and the family Medisure. Now, if you're over 60 or you're looking for a special package for your parents, then we have CIC Seniors Plan just for them. Now, do you belong to a chama or a women's group or a men's investment group? Then we have a package just for you called CIC Cop Care. Now, Professor, just to remind what we were talking about last time, just a quick recap, kwa kumbusha tu watu, tukisema recurrent pregnancy loss, tunamaanisha nini haswa?
Recurrent pregnancy loss inamaanisha umepoteza mimba zaidi ya 2. And it can, I'll be mixing Swahili and English, so don't worry, for the benefit of everybody.
Yeah.
So the moment you lose more than 2 pregnancies, then we say you have a recurrent pregnancy loss. And in most cases, there are some pregnancies where the women may not even be aware that they have lost these pregnancies. And this is what brings the whole essence of being able to understand what recurrent pregnancy loss is, what it entails, how would you diagnose it, how would you manage it, and how would you prevent it occurring in future. It's a whole subject on its own. Yes.
And then just a quick reminder, because we're now going to look into how do we then check to find for some of these causes. So there's some, we think we listed about 15 mambo ambazo zinaweza sababisha kupoteza mimba kwa mara mingi. So maybe just a quick recap, maybe just through the list of the things that commonly cause these recurrent pregnancy losses.
Now, the recurrent pregnancy loss, as we mentioned last time, we said roughly about 15 of them. We start with the major one, is that what we call undetermined cause of the loss. That is the major, and it contributes to about 50% of the pregnancy losses. The others, as we had mentioned earlier on, if you had to list them, and I list them in order of, not in any particular order, and I'll start with some of interest to everybody. One, stress in the woman is a major cause. Let's not forget about it. Nutritional element is a major cause of it. Then we have what we'll call iatrogenic. That could be because of trauma. But then we have the medical causes, which we refer to as mechanical causes, because of, and then also abnormalities in the uterus. Then we come to others which have effects on the hematological aspects of it all. We have endocrine causes. This is medical conditions like diabetes, thyroid disease, all these what people know about. Then we have what other causes like infections. Then we have the cause, some of the cause, like what you have just mentioned is when you have got cervical factors, and that is what many people know about, and it brings much more stress to the women. Yes. And then, of course, we have one of the major things which could be what we call the autoimmune events, which could be because of like the body rejecting the pregnancy. And this is where major issues arises, where the competence of the doctor is involved. You need also the good support of the laboratory. You need to have good medical care to be able to provide the necessary medications required. And as we'll mention later on, it is one of the most expensive to investigate, to treat, and eventually have a newborn with the mother.
Now, pengine sasa tunaweza angazia ni mambo yepi ambayo tunaweza tukafanya in the lab na zile imaging umezungumzia. Last week we had Margaret on the show. Now, Margaret, one of her deliveries, she had a baby who was born with an anomaly, a congenital anomaly. And we've said one of the causes might be genetic causes. Na mimba zingine alikuwa anapoteza kifikisha kama miezi 4, then zinapotea zikifika hapo. So as we are looking at these causes, how do we decide who gets what tests, and what are some of the tests that we would commonly expect? Kama nimekuja kwako kama mgonjwa, nitatarajia utanituma tests kama zipi?
Okay, the tests are many. Ziko very many investigations you can be able to do. But if you can recap from the story of Our Lady of last week,
yes,
you can divide her into 3 major causes. She had a neonatal death, meaning that you deliver your baby and you lose the baby soon after birth. She had also the component of having pregnancy beyond 20 weeks. Then she lost the baby before delivery, what we refer to as a stillbirth. That also has got its own other major causes. Then she also had got that element of losing babies in either in T1 or T2. T1 is first trimester, T2 is second trimester, T3 is third trimester. Sometimes you use those words. So if you go to hospital and you hear the doctors using those terminologies, there's nothing special about them. They're just easy way of referring to stages of the pregnancy. So the investigation, some of the causes would cut across all of them, but the investigations you carry out has a lot to do with the T level at which the pregnancy is lost. In most cases, the pregnancies which are lost in T1, most of them are either due to genetic abnormalities, we call chromosomal abnormality, which would refer to as what we call for medical terminology, so these are aneuploidy, meaning that you only have one element of the sex chromosomes. Either they are either XX or only YYs. These are what you call the aneuploidies. Then we also have got those elements of some of those autoimmune conditions, which would make the uterus, the mother now, the uterine endometrial lining of the uterus now reject the pregnancy. Now, maybe if I elaborate on this, just to bring some element of info on this. The lining of the uterus, what we call the endometrium, is basically suited for implantation. Implantation is when now the fertilized ova implants or gets into the wall or into the lining of the uterus, and then it starts developing, the placenta starts developing so that it gets its nutrition. But in the very early stages, before this implantation is fully achieved, the fertilized ova has got its own sac in which it gets its own nutrients. But when you have got those other elements which will cause abnormality within the development of the endometrium to be suitable for implantation, what you call more remodeling of the endometrial lining for the pregnancy to implant, then you'll find that the nutrients which should be available to the baby, to the growing fetus, will not be available correctly because all that element is not realized. And how does this occur? It's because within that uterus, there are what we call uterine natural killer cells. In the body, we have what we call natural killer cells, which protects us from infection. The uterus is special because it has got its own special natural killer cell, which protects the endometrium to be invaded by either the viruses, the protozoas, or anything which will cause trouble. But when pregnancy is realized and at the point of implantation, the endometrial lining changes and the uterine natural killer cells, which should have in normal situations clear off any abnormality inside the uterus, transforms and starts being protective. So it was the soldiers which are supposed to deal with anybody who is coming from outside, but there's a process which happens during the remodeling process, which now makes the natural killer cells of the uterus. There are two types, peripheral and uterine. So this one in the uterus protects now the growing ova, until the growing embryo, until now you realize this embryo grows until it reaches the stage when it now becomes a fetus. Where is this division? It is an embryo until it reaches the age of 10 weeks. After 10 weeks, then it becomes a fetus. When it is delivered, it becomes a baby. That is the process. Embryo, fetus, and then baby. So just out of interest, so that's why you find that if you go to see a doctor or an obstetrician and you tell them that, oh, my baby is kicking, the doctor will ask you, it's your fetus is kicking. So don't feel like something is wrong for you to refer to your growing baby as a baby, but the doctor says a fetus. Is just the medical terminology. So these are the important factors which are involved. So when you're doing now investigations like you asked, what are some of the things that your doctor should be able to do?
Okay. That's what we're going to come back to. So Professor anasema kuna vile ambavyo wakati zile genes za mama na baba zinaunganika makosa inaweza tokea. That is what we are referring to as genetic issues. Na pia ile nyumba ya mtoto ambayo inafaa ipokee ile mimba. Kuna wakati wengine ambapo inaleta zile vitu ambazo zilifaa kuprotect huyo mtoto, they end up attacking the baby. Those are some of the things that can cause zile miscarriages ambazo zinafanyika in the first 3 months. Sasa tunataka kuingilia ni nini ambacho tunaweza angalia, and we'll do this shortly after the break. Karibu tena Uliza Daktari. Tungependa kuwakumbusha ambapo tunaweza kupokea simu zenu kwa namba yetu ambayo iko pale chini, na SMS line yetu inapokea SMS zenyu kwenye 22422, na pia unaweza wasiliana nasi kwenye Uliza Daktari ama daktari_Mengesa. Naam, nina maswali mawili hapa ningependa kusoma Professor. Anasema, hi, I'm Lynn. I have lost 6 pregnancies with the oldest being 26 weeks and the youngest being 6 weeks. And they all happen at certain intervals. I broke up with my first husband, not because he hated me, but because I had outside pressure that it could be because of traditions on their side. The second one, I got 1 miscarriage and now I have a baby. But it took me a hard time and a lot of checkups. So she's encouraging that people should get checked up because anasema aligundua kwamba alikuwa na shida inaitwa hyperthyroidism, ambayo ni shida ya thyroid ambayo inafanya the thyroid gland was not functioning well, and that is what was contributing to her miscarriages. Mwingine anasema, daktari, nishapoteza mimba 3 times. Ya kwanza ilikuwa 7 weeks, a blighted ovum. Ya pili ilikuwa 20 weeks, anasema the water broke. 22 weeks, the water broke early. Anasema hospitalini aliambiwa akona cervical incompetence, and so they advised me next time nikipata mimba wataniwekea stitches. Now we have a call from Homa Bay. Hello.
Hello.
Hello, habari ya jioni.
Mzuri, yeye Mpolo to. Polo to anakupigia kutoka Homa Bay.
Naam, Paul.
Na shangazi yangu ambaye amekuwa na jambo moja ambalo limemsumbua sana ni jambo la mimba kutoka wakati wa mwezi wa 7.
Mwezi wa 7.
Na swali la mwisho ni dadangu ambaye amekuwa na wavulana tu, sasa anatamani kuwa na wasichana, na jambo hili limemsumbua sana akili. Sasa ameniambia nimuulizie swali kwa niaba yake. Polo to kutoka Homa Bay.
Wote kutoka Homa Bay. Rokamano. Sawa. So daktari, there are several, tumesema kuna mimba zinapotea kwa wakati tofauti. Kuna ule anasema amepoteza mimba akiwa blighted ovum. Mwingine anasema 22 weeks, 26 weeks anaambiwa maji inatoka mapema, anaambiwa cervix haifanyi kazi vizuri. The photo we shared, the lady had lost 6 pregnancies before tukaweka ile shortcut stitch. Na alikuwa anapoteza mimba zake sana ikifika hapo 14, 16 weeks, 18 weeks. So tunaweza zungumzia pengine hawa wagonjwa, tuseme pengine tuanze na ile swali imetoka Homa Bay. 7 months anaishi akipoteza mimba na 7 months. Tunaweza zingatia nini kwa mimba kama hiyo?
Okay. Mwanzo hebu tujaribu turekebishe vile watu wanairefer to jambo zingine za diagnosis. Mwanzo siku hizi hatusemi blighted ovum. Hiyo imepitishwa na wakati. Siku hizi tunasema embryonic gestation. Unakuta hizo mimba huwa zinapotea kabla haijafikisha wiki ya 10. Vile niliwaelezea hapo mbeleni, yani imegawanywa kwenye sehemu 3. Ya mwanzo inakuwa embryonic, ya pili ndio inakuwa fetal, alafu ya mwisho inakuwa neonatal. Sasa yule anapoteza mapema kabla hajafikisha wiki ya 10, inakuwa ni embryonic gestation. Na hizi inaweza kuwa kwa shauri ya vitu vingi ambazo zinaweza kuwa zinatokea. Vile niliwaambia, inaweza kuwa kitu ya autoimmune, ama inaweza kuwa ya genetic, ama inaweza kuwa ni kuna jambo ambalo linafanyika ndani ya uterus. Mwanzo kabla ili tusisahau, kuna kitu ambacho inafanya mimba utoka zaidi, na hiyo ndio sababu vile ulisema mwanzoni, inatakikana mama akiwa na mimba lazima aende kwa daktari amkague. Tena wale ambao wameshawahi kupoteza mimba mara 1, 2, 3, 4, tafadhali nenda ukaguliwe, sababu mimba ikiendelea kupotea kuna sababu. Haitoki tu vilivyo. Kuna
simu moja kutoka Nairobi, alafu tutarejea pale. Hello Grace.
Hello, habari yako?
Karibu Grace, karibu ULIZA Daktari.
Mimi naitwa Grace, niko Nairobi. Niko na mimba 20 weeks.
Mimba 20 weeks.
20 weeks. Sasa shida yangu, kabla nipate hii mimba nilikuwa niko na fibroids. Sasa tumbo inaniuma kwa sasa. Tumbo inaniuma vibaya. Nikienda kwa daktari ananipatia tu paracetamol, ananiambia sio uchungu la sasa kwa hiyo na uchungu kutoka kuzitisha. Uchungu kweli.
Naam, hiyo uchungu ya fibroids wakati mwingine inakuwa kali kabisa.
Sasa sikuwa nikisikia uchungu mbeleni, lakini baada ya kupata hii mimba, hii wiki tumeanza hii, nikienda kliniki yangu ya mwisho, nilisikia uchungu mpaka nikarudi huko kwa kliniki, wakanipima tena, wakanipiga picha, daktari akaniambia hizo fibroids zinasukuma viungo vya mwili kando. Sasa ndio sababu nahisi uchungu. Na ni uchungu kweli. Sasa ndio najiuliza, ndakaa hivi mpaka miezi 9.
Nakuelewa sana. Sawa, tutarejea swali lako. Naam.
Okay.
Asante. Hai, wacha tumalize kwanza hii, tutakuja kwa swali.
Mwenzetu from Homa Bay aliuliza swali, hebu tumjibu. Mwanzo if somebody anapoteza mimba ikifika miezi ya 7, lazima kuwe na sababu. Ile kitu hakutuelezea ni ya kwamba alikuwa anazaa mtoto kabla siku haijafika, ama yule alikuwa anapoteza mtoto. Kwa hivyo hakufafanua ili tuelewe inakuwa vipi. Kawaida ikifika miezi ya 7 inaweza kuwa ni cervix ndio inaanza kujifunguka. Hii inaweza kuwa ndio pengine kuna sababu, lakini hakutuelezea ili tuangalie kwa undani, tuelewe kwamba pengine kuna ugonjwa ama na shida fulani ambapo inaweza kuleta hii shida. Tena lazima tujue, ili tusisahau, kuna kitu kimoja tunaita placenta. I always refer to placenta as the CEO of pregnancy. Is the CEO of pregnancy. Kwa sababu placenta ikianza kuwa na shida, vitu vinaenda inaharibika kabisa. So we have to ensure that the placental function is optimum. So anything you do, you must do it with the fact that the placental function must be at its optimum level. Because the only communication the baby has with the mother, through which it gets its nutrition, its hormonal support, everything else it requires, it comes through the placenta. So the moment placenta starts failing, the moment you get up to 50% failure in placental function, that pregnancy is lost. And there are very many conditions which would cause that. And these are some of the things we had mentioned which can cause a pregnancy loss. Now, there's another important condition which can lead to pregnancy loss at this time, and everybody must be aware of it, and all women who are pregnant know. When you have blood pressure, that is something you must take cognizance about. And you know, blood pressure is brought about by so many things, and in a number of cases, it may not be apparent. Now, before I forget, the gentleman from Homa Bay also asked about sex selection.
Yes.
That this is the $1 million question every lady will ask.
Yes.
Majority will come and ask you, I have girls, how do I get a boy? Because fortunately or unfortunately, we're in a society where the male child is considered to be the optimum. So many ladies will come to you and you ask them, oh, Dr. Mangesa, how many children do you have? I'm a mother of 3 boys. I'm a mother of... So they bring out that very vividly. So those who do not have boys feel inferior, but that should not be the case. Now, to be able to have a sex selection, so many things have been tried a number of times, even at the level of IVF. And even those who do IVF, I don't do IVF, but I have an idea about what is done. They will tell you they've tried doing it and it didn't succeed. I've had a situation where, just to give an example, because so that I bring this out clearly, a mother who had had 6 girls, she opted to go for IVF. They transferred 3 embryos. She was told, these embryos, you did good selection, and they're boys. At birth, when we did the scan to then now, it was apparent that the mother, the couple, ended up being parents of 9 girls. So it is something which you say, get what you can get. But it's usually a very dicey thing to be able to do and get what you want. Medically, we know that up to 30 to 40% of women in any pregnancy are likely to get the sex they want, but it is never 100%. So it is very difficult to tell a mother that you will get the sex you want.
Thank you, Prof.
To come to the question of the lady about
we'll get to that
pain.
question just after the break. So we're looking at gender selection, we're looking at options for treatment for patients who are losing pregnancies, and we want to look into what are some of the things to do with IVF and even surrogacy when it comes to pregnancy losses shortly after the break. Karibu tena ULIZA Daktari, and together with our sponsors from CIC Insurance Group, who have family cover just for you and your loved ones at Family Medisure. For your chama, they have CIC CopCare, and for the seniors above 60, there's a CIC Seniors Plan. Now, Daktari, you are responding to ile swali tumeulizwa kuhusu fibroids na uchungu.
Yes, now, pain during when you're pregnant and you have got fibroids is a common occurrence. The important thing is that what is the size of the fibroid, what is the location of the fibroid, and what is the gestation. The lady has just told her that she's 20 weeks and she started having those pain. Most likely what is happening is that that fibroid is undergoing what in medicine we refer to as degeneration of the fibroid. Now, let the audience who are non-medics take it that degeneration means that something which is going astray. No, that's just a medical terminology we use to give the various changes of what is happening, whether it is hyaline degeneration in the fibroids or the other types of degeneration, and that can give you pain. There are various ways in which that pain can be controlled other than just using paracetamol alone. I think if the lady goes back to hospital, then there are drugs which can be used to be able to reduce the uterine irritability which must be happening, and then also to minimize the kind of events which are taking place in our scenario. So there are superior drugs which are safe in pregnancy, which we always use, and it can be able to make somebody carry on with the pregnancy. But sometimes it might be, depending on the location, it might be so serious until you may even have a premature delivery because of the location of the fibroid and what it has generated within the uterus. So good medical care is paramount. So don't sit back, go back to hospital and say, whatever was done to you last time did not help you. So can something else be done?
Okay. Now, Prof, back to our topic. Tulikuwa sasa tunataka kujua ni dawa zipi ambazo tunaweza patia hawa wagonjwa, zinaanza kwa wakati gani, and how are these patients treated?
Now, I believe you're asking about those with recurrent pregnancy loss. Now, before you start any form of therapy, first of all, like I said earlier on in the first episode we had, please ask yourself the question, why? Before you start deciding how am I going to do it. Those are the two keywords. Once you put those two words in front of you, you will be safe. Or if the lady, if you go to your doctor, please just ask those two questions. Before, how, why must proceed. So you want to know what could be the most likely cause. And normally the way to know what could be the cause is you look at the possible reasons why somebody can have a miscarriage. Then you go down the line from the history of the lady, you can be able to narrow down on the most likely conditions. Of course, if there are obvious things like cervical factors, if there are things like if there is fibroid, if there are things which you suspect is hormonal, then you do your tests. If it is something which you think is autoimmune, then you carry out the test. Now, there's one word which we always use and is always commonly used in tests in looking at women with recurrent pregnancy loss. You ask yourself, is the test I'm going to carry out, is it cost effective? Because all these tests are very expensive. And why the word cost effective comes in is, are you going to do a test which will add value or not? And in a number of these patients who have got early pregnancy losses, most of them have got these autoimmune conditions like lupus, like antiphospholipid antibodies, like those who have got anti-nuclear antibodies, those who have got rheumatoid factor. All these fall under the group of autoimmune conditions. And they're quite expensive in carrying out these tests. And this is where now the element of MDT comes in. What is MDT? It's multidisciplinary therapy. So you get multidisciplinary team to come on board. If you suspect it is hematological, you bring in a hematologist on board. If it is autoimmune, you bring in, if necessary, rheumatologist. If it's endocrine, you bring in an endocrinologist, because this is not something which you'd want to do alone. The best of success comes when there's multidisciplinary team approach. So when you suspect what could be happening, then you do that test and you now structure the treatment as per your findings. So what are some of these common things you'd be able to get, and how would this treatment be now commenced? Most of the patients, especially the ones who have got some of those autoimmune conditions like rheumatoid arthritis, which is usually you'll get there very few. Those who have got antiphospholipid antibodies, very common in those people with early recurrent losses, those with lupus. And when you do this test, the positivity you get in those who are positive is usually so mild that there's no clinical entity in the patient. So she may not even know that she has this condition. So they are usually prescribed medications which you can be able to give. In most of these patients, I have a protocol which I use to be able to look after these patients. And therefore, you'll be able to know that when you are taking care of these patients, the therapy you have to give is combined. One, you have to give medications which will take care of that medical condition. If it is an autoimmune condition, you have to bring in a steroid, which is important. You have to bring in specific medication to take care of it. And that's why you bring in things like low molecular weight heparin, which is an injection you give, because what causes the problem is inflammatory in origin, so you have to do that. Then you also, if there are those who have got lupus, you bring in what we call HCQ, so that you are able to treat this patient. There are specific other groups whereby the positivity levels is quite high, so you have to bring in other major treatment modalities which will be able to help you. This is why you can be able to bring in what you call intravenous immunoglobulin. Quite expensive. One dose in a patient, by the time you go through, will be costing millions. And that's why there are another form of a similar treatment you can be able to use. There's been a lot of controversy of its efficacy, whether it's efficacious, or this is the use of intralipid. It is much, much cheaper. I've used it for several years with excellent results. So all this multiplicity comes in. So now if you have got other medical conditions which are involved, whether it is thyroid, diabetes, hypertension, name it, you do the same. If it is something which is surgical fibroid, please, but don't do it during pregnancy. Fibroid is done outside pregnancy. If it is a cervical factor, then you do your cervical sacrilege, depending on the gestation. And as you mentioned earlier on, there are two forms of cervical sacrilege. What is the simplest one, which most people know how to do, is McDonald stitch, which came about in 1961. And the first sacrilege which came about was from 1956 from a gentleman from India called Shirodika. And it's quite a bit much more, it requires a bit more expertise to be able to do it. Now, it brings in lots of sex.
There's one last question which I feel we must answer before we close this show. Anasema utumizi wa Postina 2 pills kwa wingi yanaweza fanya mwanamke kupoteza mimba in future. Now I want us to answer this question because hizi Postina 2, yani the emergency contraceptive pills, they are commonly used. So I just want you to give this answer in 30 seconds as you give us your closing remarks.
Good question. Used everybody, by most ladies. One of our students carried at the University of Nairobi, carried a study on women who use emergency contraceptive pills. And the thrust of the study was to try and look at what is the outcome. And her study results showed that those who have used postnatal, who are emergency contraceptive pill, have a higher likelihood of getting ectopic pregnancy or pregnancy of undetermined location, PUL.
Yes.
Yeah.
So it is important to use regular contraception. Na kama ni emergency pill, there is a timing.
Use it sparingly. Not use it routinely as if it is your norm of contraception. Please.
In 30 seconds, Prof. Okay, until the time is up. But just a thank you message to you. We've got many numerous messages saying thank you for the work that you do. I will share your contacts on our pages. So tunasisitiza ya kwamba lazima tuone daktari kabla ya kupata mimba, because kuna zile investigations professor amesema lazima zifanywe ili tuweze kujua vile tutazingatia kabla ya kupata mimba, and then throughout the pregnancy there are tests and medications that we can do. So please, you're not suffering alone, but make sure you seek medical attention on time. Until next Sunday, thank you so much for joining us, and thank you so much, Prof, for joining us on this show.
Thank you.
Okay.